Welcome to the Positive Pharmacist channel. Please don't forget to subscribe, ring the bell, and leave in the comments some topics you'd like to see in the near future. One of the most common health conditions in the world at this time is depression. In this video, we'll focus on the medications that are involved in depression rather than the diagnosis part of it. But if you have any questions, please feel free to reach out to me on the email in the description below. Some possible causes of depression include a lot of medications or health conditions. We'll also talk about the neurotransmitters, but the specific one that we'll emphasize on is serotonin, because serotonin is one of the neurotransmitters involved in depression, but it has the most important role when it comes to the happy feelings that we experience. For the ADHD meds, the medications that can cause depression include Strattera, Ritalin. Some of the medical conditions we can see depression in would be dementia, the stroke, if the patient had a stroke, or if they have hypothyroidism. These are different health conditions amongst others that can cause depression. For the cardiovascular drugs, we can think of methyl-dopa, beta blockers. In terms of beta blockers, specifically propranolol, because of its lipophilicity, so it's able to cross the blood-brain barrier in the brain. The pain medications that we generally see that cause depression are those that reduce the levels of testosterone or estrogen in the body, such as methadone, but we also see it with indomethacin. So on this slide, we will be reviewing treatment assessments as well as when depression is considered resistant and the steps to take in that situation. So before assessing a patient for effectiveness of their medications, the patient needs to be on a therapeutic dose for 6 to 8 weeks. The medications usually used to treat depression do not start showing their effects in the patient's low energy for a few weeks, and in their low mood symptoms it can take up to a few months. So which is the reason why we have to wait up to 6 to 8 weeks before we can assess whether or not a drug is fully working in the patient, or if the patient is fully responding to that medication. It's very important to counsel our patients about adherence because they may think the medication is not working, so it's important to tell them that it's going to take a few weeks, but you need to keep taking it daily at the same time. Do not skip a dose. Make sure you are adherent to it. Eventually, you will see the results if that drug indeed is meant to work in them, but if not, then the doctor will be able to adjust the medications with the pharmacist's recommendation, of course. So with these antidepressant drugs that we'll be discussing, keep in mind that every single one of them has a black box warning for an increase in suicidal thoughts in the children, adolescents, and young adults. So this is a black box warning that goes with every single antidepressant drugs approved by the FDA, and these medications are never dispensed without a medication guide in order to explain it into more details to the patient who will be receiving this medication. So depression is considered resistant if it does not fully respond to 2 treatment trials. So in this case, the purple circles around that blue one are showing you the different options that we have as clinicians when the medication is not showing full effectiveness to the extent that we're expecting or would like with the patient. So after 6 to 8 weeks, one of the first recommendations is to first increase that therapeutic dose that the patient is currently on to a higher one for some time, and then assess again. Another option is to use 2 antidepressants of different mechanisms of actions so that they can work together for a better result. Other options in the guidelines recommend adding buspirone or adding an atypical antipsychotic. So in terms of atypical antipsychotics, the three that have been approved to possibly add at a low dose with other therapeutic antidepressants are Abilify, Symbyax, and Seroquel XR. The Symbyax is not very common. It's not commonly prescribed, but Symbyax contains both olanzapine and fluoxetine. So it's good to know our brands and generics. On some slides I'll be using brands, on some others I'll be using generics. So it's good to know the names of both of the drugs, both brands and generics. The first drug class we're focusing on is the SSRI. It's one of the most commonly prescribed drugs. So the drugs that are included in this class are fluoxetine, paroxetine, sertraline, citalopram, escitalopram, and fluvoxamine. Keep in mind that even though fluvoxamine is listed under SSRIs, that's how it works in terms of mechanism of action, but this medication is actually indicated for OCD, is not specifically for depression. So as you see in parentheses, I placed cardiovascular next to sertraline because in any patient that has a cardiovascular disease, sertraline is the preferred option for that patient over the others in the group. Everything, again, is approved for depression except for fluvoxamine. In terms of the side effects, SSRIs are known to cause a lot of sexual side effects such as decreased libido, erectile dysfunction. Some of these medications can also cause somnolence. Others can cause insomnia, specifically fluoxetine, because fluoxetine is a very activating drug, so it's recommended to take it in the morning. It's good to counsel our patients on that because we don't want them taking it at night and end up having issues sleeping, which will mean having more medications being added onto their plate when it's not necessary. So fluoxetine is activating, should be taken in the morning. Other drugs can be taken in the morning or at bedtime. They will not have much of an effect on their sleep. The fluoxetine also has a very long half-life. The half-life of fluoxetine is 4 to 6 days after long-term use. So if a patient was to be switched from once a week fluoxetine to from daily fluoxetine to once a week, then they need to start that once a week fluoxetine after 7 days from the last daily dose that they took. It's very important. When it comes to the MAO inhibitors, we'll see that MAO inhibitors are in the contraindications of SSRIs along with linezolid and IV methylene blue. But when it comes specifically to MAO inhibitors, the general recommendation is to space out the current medication 2 weeks from starting the MAO inhibitor. So you stop it and wait 2 weeks before you can start the MAO inhibitor to allow a washout period. But when it comes to fluoxetine, because of that long half-life, we need to wait at least 5 weeks. In the contraindications, we also see paroxetine, specifically the brand name Breezdale, that is contraindicated in pregnancy. So in pregnancy, the first line recommendation is psychotherapy over medications. Now, if that does not work, that's when we look at SSRIs, but paroxetine will not be an option for a pregnant woman. In terms of warnings, QT prolongation is a side effect that we see with a lot of antidepressants, but in the SSRIs, we'll see that it's mostly common with citalopram and escitalopram, which is the reason why these two drugs have maximum daily doses recommended for everyone else as well as for the elderly specifically. So for the citalopram, 40 milligrams daily is the maximum per day for any other healthy person, but when it comes to the elderly, they are at a greater risk of QT prolongation, so it's reduced to 20 milligrams a day. With the escitalopram or Lexapro, 20 milligrams daily is the max, but with the elderly is 10 milligrams. We also want to keep in mind that SSRIs could possibly increase the bleeding risk if it's taken alongside other medications that can cause bleeding as well, that can increase the bleeding risk as well, such as NSAIDs, antiplatelets, anticoagulants. Any of those taken together with SSRIs would increase the bleeding risk of the patient. It has also been observed that in the elderly, they experience more of the low sodium from SSRIs, so it's good to look out for that so that they do not end up developing SIADH. The very last bullet on this slide is a drug that has both the SSRI mechanism of action in addition to a serotonin 1A partial agonist mechanism of action. This drug is the Vibrate. It's very seen in practice, it's commonly prescribed in practice, and this is good to know because it has less sexual side effects compared to SSRIs. So it has both the mechanism of actions of the SSRIs in addition to the serotonin, so it increases even more serotonin levels compared to just an SSRI alone, but the benefit is that the patient is not going to have that decreased libido or erectile dysfunction. The next drug class we want to look at is serotonin and norepinephrine reuptake inhibitors. The drugs involved in this class are Effexor, Cymbalta, Pristiq, and Fedzima. I want to point out that just because a drug is listed in this chapter does not mean that the only indication it has is depression. So for example, with Cymbalta can also be used for nerve pain. So therefore, if a patient has nerve pain in addition to depression, a good option to place them on would be Cymbalta because that would reduce the number of drugs that patient has to be on, which will also reduce their risk for drug interactions and their risk for additional side effects. So it's good to keep that in mind, that when you see a drug in a patient's chart, you do not want to just assume that they are taking this drug for this indication. It's always good to either reach out to the patient if they are able to respond to that question, or reach out to their prescribers to find out why they place the patient on that specific drug. In terms of side effects of SNRIs, the side effects are going to be similar to the SSRIs that we saw on the previous slide, because they are also blocking the reuptake of serotonin in this case, but in addition to that, they are also blocking the reuptake of norepinephrine, which is another key neurotransmitter when it comes to depression. So we'll see the side effects of SSRIs, which involved the sexual side effects, but we'll also see increased heart rate, blood pressure, dilated pupils, dry mouth, increased sweating, constipation, and those side effects come from that fight or flight mode. Norepinephrine is a neurotransmitter that is increased in the brain during a fight or flight mode. Or when I think fight or flight, I think of someone being chased by something dangerous, and when you're being chased, you run. So I think of someone exercising as well. If you look at the man at the bottom, he's sweating from exercising. His pupils are probably dilated. He has a dry mouth. When you exercise, you're very thirsty. So if you think of that and you think of norepinephrine as being involved in fight or flight mode, it's going to be easy for you to remember the side effects of the serotonin norepinephrine reuptake inhibitors, and just add these side effects from the sweaty man exercising to the ones we saw on the previous slide to know the side effects of SNRIs. In terms of contraindications, we do not want to take these drugs simultaneously with the MAO inhibitors or linezolid or IV methylene blue due to the risk of hypertensive crisis with the MAO inhibitor. So usually, again, like I stated before on the last slide, we want to space them out by at least 2 weeks. But when it comes to fluoxetine, space them out by at least 5 weeks with the MAO inhibitors. The Effexor in this slide is a key one to talk about because it increases the blood pressure risk. It increases blood pressure in the patient, so it increases the risk of that hypertensive crisis even more if a patient was to take Effexor with a MAO inhibitor. So the increased blood pressure risk is greatest with the Effexor if the patient is taking anything greater than 150 milligrams per day. The Effexor can also cause QT prolongation, just like we saw with SSRIs, but again, it's not surprising because that was one of the warnings in SSRIs, and given that these drugs do have that part of the mechanism of action, it's not surprising to also see it come up with the drug here. So both the SSRIs and SNRIs need to be tapered down when the patient is discontinuing the medication in order to avoid withdrawal symptoms, except for fluoxetine due to its long half-life. Fluoxetine does not need to be tapered down. The patient can stop it today and be fine because it's going to slowly reduce in their bloodstream, whereas the other ones have shorter half-lives, so it's good to taper it down to avoid having any withdrawal symptoms. Tricyclic antidepressants are the next ones we'll be talking about. The tricyclic antidepressants generally inhibit both the serotonin and the norepinephrine as seen with the other two classes, but now we also see that they block the acetylcholine and the histamine receptors, which is why we will now see additional side effects that are anticholinergic in addition to some of the side effects we previously saw. So with the side effects, we see QT prolongation. Again, is not surprising because it's inhibiting both serotonin and norepinephrine receptors. But here, QT prolongation is common in case of overdose. We also see orthostasis. So these drugs can cause fluctuation in blood pressure, so it's very important to explain to our patients, especially the elderly, that it might increase their fall risk because if they go from one position, for example, lying down to sitting, or from sitting to standing up too quickly, it would increases their chances of falling, might make them lightheaded. So it's important to counsel our patients on that with these drugs. So both tertiary amines and secondary amines have similar side effects and contraindications, which is why I did not repeat them again on the second part of the slide. Contraindications are similar. You'll see that we keep repeating the same things. MAO inhibitors, linezolid, IV methylene blue. You want to stay away from them while the patient is taking these antidepressants. In terms of tertiary amines and secondary amines, studies have shown that tertiary amines are slightly more effective than the secondary amines, but they also display more side effects. So with the side effects again, we see dry mouth, constipation, blurred vision, urinary retention, because these are anticholinergic side effects. When we think of cholinergic side effects, they are usually the opposite of fight or flight mode. So if the opposite of fight or flight is more like relaxation, when you're relaxed, you have saliva in your mouth, think of enjoying a meal. You can go to the restroom with no issues. You don't have constipation. You don't have urinary retention. Your vision is clear. You are happy. But when it's anticholinergic, now you have to think of all the opposites of those relaxation things that you might experience. So this is why we see now dry mouth, constipation, blurred vision, and urinary retention, because that acetylcholine receptor is being blocked. So now we see anticholinergic side effects. The next drug class is the monoamine oxidase inhibitors. These are the MAO inhibitors that I kept mentioning with all the other drugs, if you did not know. So some of the common drugs in this drug class are Marplan, Nardol, and Parnate. These are all brand names because the generic names are kind of long and difficult to pronounce. But Marplan, Nardol, and Parnate are the three common ones in this drug class. Some of the side effects include, again, anticholinergic effects that we saw on the previous slide, as well as orthostasis, so it can cause fluctuation in the blood pressure of the patient if they go from one position to the other too quickly. This can also cause weight gain, erectile dysfunction, and headaches. So these are some of the common side effects. In terms of contraindication, we do not want to use these drugs in a patient with cardiovascular disease if they have history of headaches, again because it's one of the side effects. If they have cardiovascular disease, orthostasis is not good, as well as the risk for hypertensive crisis that a patient could experience if they are taking a tyramine-rich food. Because remember, we did stress that we should not take the MAO inhibitors simultaneously with any of the drug classes that we have already discussed. But another risk for them is if they take a tyramine-rich food. So by that means anything that has been aged, anything that has been smoked, dried, fermented, for example, like pasteurized beer, some red wines, or anything pickled. So if you think of anything like air-dried meat, as the picture shows there, or aged cheese or red wines, while taking this medication can place the patient at risk for hypertensive crisis. And given that that's a lethal condition, we do not want to place our patient who already has a cardiovascular disease at risk for this. So keep those contraindications in mind. If they have liver disease, history of headache, or cardiovascular disease, this drug class is a no-no. But it's usually not common to see patients on this medication unless the other drug classes have not shown any effect or any benefits at all. Some of the side effects that a patient, or some of the symptoms of hypertensive crisis that a patient might experience, if you're wondering, would include severe headaches, palpitations, sweating, chest pain, stiff neck, things of that sort can be presentations of hypertensive crisis. Excuse me. The next drug class is the dopamine and norepinephrine reuptake inhibitors, DNRI. So the one drug that we'll stress here is the bupropion, Wellbutrin XL or XR. I did not include some other drug names here because they were not indicated for depression. So I'll just focus on the depression drugs for the sake of time. In terms of side effects, this drug can cause dry mouth, insomnia, tremors or seizures, weight loss. Sexual side effects are very rare with this one, so it's a good thing to know, because if a patient is having issues with SSRIs or SNRIs, where they have a lot of sexual side effects, you have Vibrid that has less of the sexual side effects. In addition, you also have bupropion as another option where the sexual side effects are rare. We also want to know that this can cause seizures because it reduces the seizure threshold in a patient. So think about a patient who is already taking some seizure medications, and now they are placed on bupropion. It's really going to mess up their therapy. So we want to be careful, want to make sure that we treat our patient as a whole, that we look at the entire patient, all the health conditions and everything, all the drugs that they are taking, before we add on anything else to their list. In terms of contraindications, we do not want to give this medication to a patient who has eating disorders. Of course, we know that it can cause weight loss, but we do not want any patient to abuse of it for that benefit. So anyone with eating disorders, whether it's anorexia or bulimia, it's a no-no. They cannot be on this drug. MAO inhibitors, linezolid, IV methylene blue, remember they keep coming up as a contraindication with all the antidepressants, so it's good to keep them in mind. If the patient is on some other forms of bupropion, they could be taking Zyban for smoking cessation. That's still bupropion. You do not want to give them two different forms of bupropion. So again, that's why it's good to know our brands and generics. If a patient has a seizure disorder, we have already discussed that. It's a contraindication, so this drug will not be good for them. So if a patient, for example, was on an SSRI or SNRI and they had sexual side effects and they have seizures, If you're considering a drug that has less of those side effects, then in that case you might consider Vibrate over bupropion, because bupropion is going to reduce the seizure threshold and interact with some of the drugs that they are currently on, so we do not want to place them at that risk. For the warnings with this drug, no patient should be exceeding the 450 milligram daily mark. No one should be exceeding that. So that would increase the risk for seizures and tremors even more with that patient. So that's just a limit you have to keep in mind when you're verifying prescriptions as a pharmacist. Keep in mind that even when the doctor places a patient on the bupropion, the Wellbutrin, 300 milligrams a day, and the Wellbutrin 150 a day, that's the max they can take. The doctor cannot start asking the patient to take 2 of the 150 and 1 of the 300 altogether. No, that's wrong. So make sure you keep that in mind. 450 milligrams a day is the maximum for bupropion XL or SR. Other antidepressants that we'll be looking at, these are mostly taken for sleep, usually are mirtazapine and trazodone. So mirtazapine can also be used to help with sleep or to increase appetite, especially in cancer patients, which is pretty much some of the benefits of its side effects. The side effects of it are to the benefit of the patient in this case. So we see sedation, we see increased appetite, which in turn will lead to weight gain. So with the trazodone is primarily used to help with sleep, but therefore, since both of them can cause sedation, both are given at bedtime. Trazodone can increase the risk of falls of the patients, especially in the elderly. Again, we want to counsel on that orthostasis and the possibility of the drug causing lightheadedness. So we want to make sure our patients are aware of it and can take precautions like holding the bed rails and holding the side of the chair when they are standing up, or the side of the bed when they are standing up, sitting up from laying down position, so they do not faint. Another key side effect with trazodone to remember is the risk for priapism. And priapism is pretty much when a man has an erection that lasts for more than 4 hours. At that point, it's considered an emergency situation and he would need to call 911. So again, keep in mind, this is the last slide, but keep in mind that with all of these antidepressants, all these drug classes that we covered, I did not put black box warning, but I did mention it from the first slide. And we want to remember that with every single one of them, they have a black box warning that they can increase the suicidal thoughts in children, adolescents, and young adults. We want to stress that out because if the family members were to notice a change in the mood or the behavior while the patient is on these drugs, that can put their lives at risk. It's important for us as pharmacists and for the doctors as well to be aware so that the medication can be changed or slowly tapered down, switched to another one. So just keep that in mind. If you have any questions, again, do not hesitate to reach out to me. On that note, thank you for watching this video. And please, again, I would love to receive feedbacks and comments on topics you would like to see in the near future. And see you next time. Bye-bye. Good luck with your studies and with pharmacy school. Bye-bye.